I call upon Dr. Arya, Assistant Professor from RIO, for her topic. Discussion is on basics of strabismus evaluation.
Good afternoon. At the outset, let me thank Dr. Vijayamma Madam for giving this opportunity. My topic is revise the basics of strabismus evaluation. So what are the goals of a basic strabismus evaluation? To find the etiology, to assess the binocular status of the patient, measure the amount of deviation, to diagnose amblyopia, which is very, very important in a strabismus evaluation, and to define a definite plan of management. In the examination part, you have to take a detailed history, including the birth history, family history, and also history of using any spectacles, patches, or any surgeries done in the past. Cycloplegic refraction is very important, without which a strabismus evaluation is incomplete. Fundus examination to rule out any other sensory cause for strabismus. Measurements of deviation, ocular motility examination, as well as the sensory tests. Now, examination of squint consists of assessment of motor status as well as sensory status. The motor status examination consists of head posture, where we have to look for face turn, head tilt, chin elevation or depression, ocular deviation, extraocular movements, and vergences. Now, where do we get this abnormal head posture? You have to think about a paralytic, restrictive, musculofacial anomalies, A or V pattern producing the HP, nystagmus, refractive errors, undercorrected glasses, field defects can also produce an abnormal head posture. So in this picture you can see, first is a child with left head tilt having a right esopalsy and right hypertropia, and on the left hand side you can see a child with left face turn having a left lateral rectus palsy. Now this is again a child with nystagmus having a right face turn, since she is having a null zone towards her left side. Now, abnormal head posture can be assessed from around 6 months of age once a child starts sitting up. And this was a child with left head tilt, and on assessment she was having a tight sternocleidomastoid on the left side, which is a very important non-ocular cause of torticollis. So that also has to be kept in mind. We have to rule out a pseudostrabismus. In the picture you can see the child is having a broad nasal bridge, telecanthus and epicanthal fold, which produces a strabismus appearance. We need only a simple test to differentiate pseudostrabismus from strabismus, that is our cover test. So what are the important light reflex tests in strabismus evaluation? Hirschberg test, Krimsky, and Bruckner reflex test. So Hirschberg test, we know it's a very simple test. You shine torch and look for where the pupillary light reflex is falling, and depending upon the position, you can grade it accordingly as shown in the slide. The prerequisites are the child should be able to fixate, cooperation of the patient, and the cornea should be clear. In this picture, you can see by Hirschberg test, we can assess whether the patient is having an exotropia. Here also the pupillary reflex is falling in the pupillary margin. Now Bruckner test is a very simple screening test. For this, you have to shine the light from a direct ophthalmoscope into the eyes of the child at a distance of 1 meter in a dimly lit room. If it is symmetrical, it is normal. Asymmetric reflex is got in cases of refractive error, manifest squint, amblyopia, retinal pathologies, and media opacities. Next light reflex test is a Krimsky test, where you place the prism in front of the patient's eye, and in Krimsky you place it before the deviated eye, and you make the light reflex exactly fall in the center of the pupil. In modified Krimsky, you place it in front of the normal eye. Now for the cover test, we need a target. You can use toys also for very small children, and an occluder. Here you can see you have to give an accommodative target for the patient and occlude the fixing eye. You can see the movement in the left eye. It is coming from out to in. So a cover test helps us to find out a tropia. Next, you can see in this video, the child is fixing on a target. We are covering the eye. The child is orthophoric. And you can see once you uncover the eye is coming from out to in. So by the uncover test, we find out a phoria. Now it is an alternate cover test where you cover the eyes alternatively and you see for the movement of the eyes. So by the alternate cover test, we bring out the components of both the tropia and phoria. So what are the prerequisites for this test? The patient should be able to fixate, central fixation, no gross or severe motility defect should be there. And when this test can be fallacious, in markedly subnormal vision or when the patient is blind, severe restriction or limitation of the extraocular movements and eccentric fixation. Now, the points to remember when you do a cover uncover test, it should not be done too slowly, not too fast also. And while recording, you have to estimate its degree, type of deviation, and also the speed of recovery, whether it is good, fair, or poor. And by the cover test, you can identify other conditions also, like latent nystagmus, pseudotosis, pseudostrabismus, and eccentric fixation. Now, we have to measure how much deviation the patient is having. For that, you have to do the prism bar cover test or the prism test, where you can use the loose prisms as well as the prism bar. So what are the prerequisites? Again, the patient should be able to fixate the accommodative target, refractive correction should be worn, and this test can be affected by the refractive error. So in this test, you can see you are doing an alternate cover test. After that, to neutralize it, you are placing prism bar in front of the patient's eyes. And the prism should be placed in such a way that its apex is directed towards the direction of deviation. In the slide, in the video, you can see the child is having an exotropia, and hence the prism is directed with apex outwards, and you increase the power of the prism till there is no movement of the eyes. Now you can see there is no movement of the eyes, and then you record the power. Now, deviation should be measured for near as well as distance, with and without glasses, in the 9 cardinal positions, in up gaze and down gaze, up gaze at 25 and down gaze 35 degree, to differentiate whether there is an AV pattern. If there is a difference of 10, it fits into A, and 15 V pattern. And after prolonged cover test also. Now coming to the extraocular movements, you should record the uniocular movements, ductions, binocular versions, and vergence in the 9 gaze positions. So in the video, you can see the child is not able to abduct in the left eye. The child was having a lateral rectus palsy. Again, the child is looking towards his left side. Abduction is limited in the left eye. And in the next slide, you can see that there is a retraction of the globe, narrowing of the palpebral fissure, as well as a downshoot on adduction. So this child was having Duane's retraction syndrome. Again, in the upward movement, the patient is not able to look upwards. The patient was having an inferior orbital wall fracture with inferior rectus entrapment. And here there is a limitation of elevation in adduction. This was a child with infantile esotropia. You can see the child is looking towards the left. The child is cross-fixating. But on covering the eye, you can notice that the adductions are full. This is a very important test to differentiate it from a congenital lateral rectus palsy. Now, convergence you can measure with the RAF ruler. Now, what are the subjective tests of ocular deviation? Diplopia charting, where the patient wears a red-green goggles and tells you how he sees the images. The Maddox road test, depending upon the shift of the image, you can diagnose an exophoria or esophoria. Hess charting. And how do you measure the cyclodeviation? You can measure it with the help of a double Maddox rod. Also, you have to identify the fundus torsion, where the fovea will not be corresponding to the midline of both these lines, midpoint of both these lines. Now you have to examine the sensory status, where you assess the binocular status, diplopia, correspondence, suppression, amblyopia, which is very important, and you have to grade the stereopsis. For sensory adaptation, we use a Bagolini glass and diagnose what the child is having. Wirtz Fodor test also the same purpose. Bilshowski's aftermage test, and the special test done in strabismus evaluation, FDT, FGT, EMG, and Chancellan test. Thank you for the patient listening.
Thank you, Adia, for your an excellent talk. She has covered all the points, but in a simplified way, how to evaluate a case of strabismus.